You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is January 26, 2024. We are doing a journal club covering Could Biologic Therapy Be a Solution for NSAID Tolerance in AERD Patients? Presented by Dr. Michelle Manious. She is an Allergy and Immunology Fellow at Children's Mercy Hospital.
So I am Michelle, one of the first-year fellows here presenting for Journal Club, and the title of this one is Could Biologic Therapy Be a Solution for NSAID Tolerance in AERD Patients? Does it want to go to the next slide? There we go. And so here's just a little snapshot of the article that I picked. It's titled Non-Steroidal Anti-Inflammatory Drug or NSAID Tolerance After Biological Therapy in Patients with NSAID-Exacerbated Respiratory Disease, a Randomized Comparative Trial. And this one was published in the Journal of Allergy and Clinical Immunology in, I believe, July of 2023. Authors are from Colombia, and they are Sanchez, Garcia, Lopez, Cal, and Buendia. And before kind of getting into the presentation and like going through the article, I wanted to do like a little brief review about like what is NSAID ERD or NERD, we'll call it. More commonly, we see like it titled as aspirin exacerbated respiratory disease, but NSAID kind of combines all the other NSAIDs. And it's a chronic inflammatory disorder of the respiratory tract that is triggered by NSAIDs that inhibit COX-1. And the article actually defines it as NSAID exacerbated respiratory disease, NERD, is a chronic eosinophilic inflammatory disorder of the respiratory tract occurring in patients with asthma and or rhinosinusitis with nasal polyps, which symptoms are exacerbated by NSAIDs, including aspirin. And clinical features, it's characterized by Samter's triad, which is chronic rhinosinusitis with nasal polyps, asthma, so like difficulty breathing, wheezing, cough, and then NSAID hypersensitivity, and that includes severe reactions following ingestion or inhalation of NSAIDs, including breathing difficulties, facial swelling, and anaphylaxis. ATP and positive sensitization is present in about 65% of AERD patients. Systemic symptoms such as rash, GI upset, and urticaria can occur as well. And nasal polyps have a more aggressive course. If those are present, usually they have a higher incidence of polyp recurrence and needing polypectomies, and sometimes like more than just one, and they'll need like revisions of their surgeries. And approximately 80% of patients with AERD report respiratory reactions to alcoholic drinks, usually developing within 1 hour of ingestion. I thought that was interesting too, because I know I actually saw a patient recently, coming in, every time I drink alcohol, I have like rash and this is kind of something that triggered my thought. I was like, I never actually asked her about like NSAIDs in this setting, so that was interesting, if that could be contributing. Prevalence. So generally recognized as an adult onset disease, it typically develops suddenly between the ages like 20s to 50s. And a reliable estimate is not yet established due to the lack of diagnostic assays and reliance on self-reported symptoms from patients. Overall prevalence is 7.2% in patients with asthma, 14.9% in those with severe asthma, and then 9.7% with asthma and chronic rhinosinusitis with nasal polyps. And it disproportionately affects women greater than men, so 57% women and 43% men. And then here I just have a review of the NSAIDs and a nice little table here, or not table, a little flow diagram on the right to go over. But primary effect is that they inhibit cyclooxygenase. They impair the transformation of arachidonic acid to the prostaglandins, prostacyclins, and thromboxanes, and you can see that here on the right. So we have NSAIDs working on COX-1 and 2, and it kind of inhibits the rest of these downstream from being formed. And Weak inhibitors of COX-1 are usually well tolerated in aspirin hypersensitivity, and this includes acetaminophen. And selective COX-2 inhibitors include celecoxib and the other ones listed here, and these are generally well tolerated in patients with aspirin sensitivity. And the way aspirin works is basically it's a inhibitor of both COX-1 and COX-2. More notably inhibits COX-1, and it's irreversible for both, and that's through acetylating a serine residue near the active site, and it kind of hinders access of the arachidonic acid to the active site. And then COX-2 doesn't affect COX-2 as much because it's a little less potent due to the fact that the substrate channel of COX-2 is a little bit larger and more flexible than that in COX-1. So it doesn't really have that kind of binding as easily there. Or sorry, can more easily bind there compared to COX-1. And then pathogenesis I have here. It's a non-IgE mediated reaction. It blocks COX-1, and so when you kind of block COX-1 here, you get overproduction of this pathway. So you go more towards the leukotrienes down here, and then when you have increased leukotriene D4, you get the acute bronchoconstriction, increased vascular permeability, and prostaglandin E2. When you block COX-1, one of the downstream molecules is the prostaglandin E2 that's typically blocked as well. Typically, this acts as a brake on this pathway, the 5-lipoxygenase pathway, and so when you block this pathway and you don't have something that blocks the 5-lipoxygenase pathway, this kind of takes into effect and you have increased of those leukotrienes that kind of cause that bronchoconstriction. And yeah, I have normal function of PGE2 inhibits the 5-lipoxygen pathway. Mechanism of action. So again, non-IgE mediated reaction involving dysregulation of the arachidonic acid metabolism with overproduction of leukotrienes. And then here on the left, I have like aspirin exacerbated respiratory disease, like these patients at baseline, and they do have less of the prostaglandin E2, so more kind of production of the leukotrienes, as I mentioned on the last slide, leading to that smooth muscle constriction. And then on the right here, I kind of have the effect of when aspirin is introduced. And so PGE2, like I mentioned, acts as a brake on the leukotriene synthesis and blocks the 5-lipoxygenase pathway. And so when COX-1 is blocked, you get overproduction of the prostaglandin E2. So that leads to overproduction of leukotrienes and then smooth muscle constriction, airflow, and obstruction, worse than before. Diagnosis remains primarily a clinical diagnosis, but things that we do in this scenario is we evaluate for Samter's triad, as I mentioned before, looking at PFTs, nasal endoscopy, and through a patient's history. And then you can also do a formal aspirin challenge for those with an unclear history. Current treatment approaches are surgery to remove nasal polyps, montelukast to kind of block the leukotrienes, the cystinoid leukotriene 1 receptor that kind of plays a big role in this, Zolutin, which impairs leukotriene reduction by 5-lipoxygenase inhibition, intranasal steroids, aspirin therapy after desensitization, diet, like avoiding foods that are high in salicylic acid, avoiding COX-1 inhibiting NSAIDs, and then biologics for asthma with nasal polyps like omalizumab, mepolizumab, and dupilumab. And now we're kind of approaching the study that I was looking at and the clinical significance. Aspirin after desensitization is fairly effective, and patients can use daily aspirin indefinitely without side effects, but the rate of adherence is kind of variable. It's 30 to 80% in the first year, and the patients need to take aspirin daily after that to maintain protective effect. So it's a lot of work for some patients, and then it's not always successful. Why this study is cool is basically there's not a lot, well, there is evidence that biologic therapies have benefit in the treatment of asthma and chronic rhinosinusitis in patients with AERD, but there's very limited data about biologics and NSAID tolerance. There have been few cases about omalizumab, dupilumab, and how they improve NSAID tolerance, but the study that I'm about to kind of introduce and talk about is the first prospective study evaluating the impact of 4 biologic therapies on NSAID tolerance and NSAID exacerbated respiratory disease. And so just again, here is kind of the little snapshot of the article. And the clinical question for this study is, in patients diagnosed with NSAID exacerbated respiratory disease or NERD, does the administration of biological therapy result in a significant difference in NSAID tolerance after 6 months of therapy? In study design, this was a prospective before and after study that was conducted between February of 2020 and March of 2022. It was a randomized comparative study looking at the effects of biologics on NSAID tolerance in patients with NERD. Population was 20 men and 18 women, and they were adults over 18 years old with type 2 inflammation and NERD. NSAID hypersensitivity, CRS with or without polyps, and severe asthma. The mean age of the patients in the study was 49.5, 49.5 years old, and the setting was in Colombia, in a clinical setting. Selection criteria for the patients that were included in the study: they were 18 or over, they had a history of respiratory NSAID sensitivity, they had chronic rhinosinusitis with or without polyps, severe asthma with an indication for a biologic therapy, as noted on step 5 of GINA guidelines, and type 2 inflammation, which is defined as presence of atopy, total IgE over 100, or absolute eosinophil count of over 150. And the diagnosis of NERD was done with diagnostic aspirin challenge test. Exclusion criteria, so patients that were not included in the study include those that should have the possibility of receiving any of the biologic therapies. So if one had only one of the 3 biomarkers, just sensitization to an aero allergen, but they did not have elevated IgE or eosinophils, they were not enrolled. People also that were not enrolled are those that have received other biologic therapies in the past or present, those that have received NSAID desensitization in the past, those with a history of anaphylaxis to NSAIDs, and those with the Lund-Mackey scale greater than 16 or Lund-Kennedy score greater than 4, which are severity scores for chronic rhinosinusitis. It's always a mouthful. And then confirming the diagnosis. After patients were screened, a diagnosis of NERD was confirmed with a diagnostic aspirin oral challenge test. And so this kind of consisted of starting with 50 milligrams of aspirin, followed by 125 milligrams, then 250, and then 500 every 90 minutes. The total cumulative dose was 925. And if you see on the right, 54 patients met the clinical and paraclinical criteria. And then a positive test was defined as those with nasal or respiratory symptoms, including 20% decrease in PEF or symptoms of sneezing, obstruction, runny nose. And then a positive test also was having non-respiratory symptoms, including angioedema, hives, and loss of consciousness, also cardiovascular, neurological, or GI symptoms. And 38 patients had a positive aspirin oral challenge test. The doses of the biologic therapies were administered according to the indication for asthma based on the GINA guidelines, and all patients had an indication for a biologic therapy for severe asthma targeting type 2 inflammation. Between the groups, there was not a significant change in the concentration of aspirin to which patients reacted in the first aspirin oral challenge test, and most patients reacted after the 125 milligram dose. After they've received 175 total. The most frequent reactions during this time was respiratory symptoms. In some patients, the test was stopped because of presence of cutaneous or GI or blood pressure changes. All patients during the diagnostic challenge test, like before getting the biologic therapy, also showed respiratory symptoms confirming that they had the presence of AERD. So now that we've kind of confirmed the diagnosis in these patients, we'll go on to the study design. And if you look here, I have the rest of that little flow sheet that they had in the article. The 54 patients, if you look on the left-hand side, that met the criteria, kind of went on and they had that positive. They did the testing to look and see, did they have that positive aspirin oral challenge test? And 38 of the 54 did. And those 38 then kind of went on to the next step where they were randomized into receiving one of the 4 biologics. They looked at benralizumab, dupilumab, mepolizumab, and omalizumab. It was about 10 in each group, 9 to 10. And then those patients were placed on those biologics for about 6 months, and then they were kind of reassessed for symptoms at that time. And so the way that they picked which patients would go into each of those groups receiving one of those biologics, they performed randomized restricted block assignment of the 4 different categories, and they were stratified to presence of nasal polyps and the SNOT 22. And it was not blinded. So the patients kind of knew, and the clinical investigators knew kind of which group these patients, which biologic these patients would be taking. And unfortunately, something that happened during this study was that the dupilumab was approved in 2021 in Colombia. And so after that, the national health system in Colombia required usage of dupilumab over the alternative biologics. And so this kind of affected the study with, recruiting and then kind of sample size as well. So I thought that was something that was like important to note of. And then intervention. So 38 patients were randomized, like I mentioned on the last slide, into taking those biologics for 6 months. And the doses for the biologics were kind of created based on the severe asthma-based dosing recommendations in the GINA guidelines. So 9 were in the benralizumab group, and these ones received 30 milligrams sub-Q injection every 4 weeks for 3 doses, and then every 8 weeks. There were 10 in the dupilumab group, and those patients received 300 milligrams every 2 weeks for those that had, for those with dependent asthma, and then 200 every 2 weeks for those that did not have asthma. OCS-dependent asthma. 9 were in the mepolizumab group, and those got 100 milligrams sub-Q every 4 weeks. And then 10 in the omalizumab group received weight-based dosing based on their serum IgE and their weight, and they received that every 2 weeks. The primary outcome of this study was proportion of NSAID intolerant patients who developed complete NSAID tolerance after 6 months, defined as the absence of immediate or delayed reactions during the aspirin oral challenge test after total dose of aspirin being 925 milligrams. And then findings for this study. So in all groups, there were patients who achieved complete tolerance to NSAIDs. Omalizumab and dupilumab showed the highest frequency of complete tolerance, and the omalizumab group tolerated a significantly greater aspirin dose than the anti-eosinophilic groups. And here on the left, you see aspirin oral challenge test before the biologic therapy and the aspirin dose that kind of triggered the reaction with each of the biologics that they were put on before. And then after being on the biologic, you can see kind of what the aspirin oral challenge test dosing was after, and you can kind of see they tolerated higher doses, more notably in the omalizumab group and the dupilumab group, the green and the purple. And kind of in this figure, in A, you can kind of see the comparison of the groups before starting the therapy that did not present really statistical differences, but on the B portion of the figure, you can see this was statistically significant, and it kind of shows the comparison after 6 months with biologic therapy according to the concentration of aspirin tolerated, favoring omalizumab, like I mentioned, over the anti-eosinophilic therapies, but not over dupilumab. And then the number of patients achieving NSAID tolerance of those, omalizumab and dupilumab were better than the anti-eosinophilic therapies. And then study design results for the primary outcomes. So the proportion of patients that developed complete tolerance, we have in the omalizumab group, the p-value was less than 0.01, so significant, and 6 out of 10 showed complete tolerance, or 60%, and 3 out of 10 had a higher tolerance to aspirin. 1 out of 10 had equal tolerance before and after biologic. With the dupilumab group, p-value of 0.04, so significant as well. 4 out of 10 had complete tolerance, so 40%. And then 3 out of 10 had higher tolerance when comparing before and after biologic, and then 1 out of 10 had equal tolerance. Mepolizumab, benralizumab, these ones, 22% for mepolizumab had complete tolerance, and then 1 out of 9 had higher tolerance, and then 5 out of 9 had equal tolerance before and after, and 1 out of 9 had actually lower tolerance. And then with benralizumab, 2 out of 9 had complete tolerance, and then 2 out of 9 had higher tolerance, and 5 out of 9 had equal tolerance. And then for secondary outcomes, omalizumab and dupilumab had higher cumulative dose of aspirin dose tolerated after 6 months of biologic therapy compared to baseline. So omalizumab group tolerated higher doses of aspirin. Net increase was 562 milligrams, and this was statistically significant. And for dupilumab, this group tolerated higher doses of aspirin as well. Net increase was 387, and this was statistically significant. For mepolizumab, not statistically significant, p-value is 0.58, and same with benralizumab. Net increase for both of them was about 180 milligrams, but not statistically significant. And then I liked this image that they put in their paper, kind of a little summary slide. It just kind of overview what we talked about. It shows that on the left, they started with patients with asthma, chronic rhinosinusitis, NSAID AERD with a positive aspirin oral challenge test. Again, these patients were randomized to take one of the 4 different biologics looked at for 6 months, and they were compared before and after. And most significant, you see with aspirin oral challenge test, the ones that had significant evidence that they had like complete tolerance were dupilumab and omalizumab, and then more notably with the aspirin oral challenge test and needing like a higher dose than before with partial tolerance, 40% dupilumab, omalizumab 30%, and then positive aspirin oral challenge test with equal or lower dose than before, no change. You see 20% dupilumab, 10% in omalizumab. But no change was seen mostly in the benralizumab with 55% and the mepolizumab 66%. So study design results, possible prognostic factors. There was no association between high eosinophil count, high total IgE, and a higher tolerance after biologic therapy. There was no association with aspirin oral challenge test results and a change in ACT or SNOT scores. And there was no association with aspirin oral challenge test and nasal polyps or sinus surgeries. And there was no association between intensity of symptoms like nasal bronchial or anaphylaxis, the affected system, or the result of the provocation test after starting a biologic therapy. And this kind of brings us to the discussion of this article. So several studies show that dupilumab, benralizumab, mepolizumab, and omalizumab are useful for asthma and CRS in patients with AERD. However, this is the first prospective study and head-to-head trial evaluating the impact of the 4 biologic therapies on NSAID tolerance in NSAID ERD. Biologics can increase NSAID tolerance in patients with NSAID ERD with type 2 inflammation characterized by atopy, high total IgE, high eosinophils, with omalizumab and dupilumab appearing to be most superior to the anti-IL-5 agents. And appraisals for study design. So I thought strengths for the study were that they had a very good design. They were randomized control trial, which kind of helps minimize bias and strengthens causal inference about the effectiveness of different biologic therapies. It was a comparative exploratory analysis, so allows like identifying differences in efficacy between the 4 different biologic therapies, which could kind of help inform future research and clinical practice. And then objective outcome measures. Aspirin oral challenge test provides standardized measure of NSAID tolerance. And then weaknesses, I thought it was a small sample size, so 38 total. A larger sample size usually is needed to kind of confirm these exploratory results. It was a single center study, which kind of limits generalizability to other institutions and patient populations. And there is lack of blinding, which could lead to some biases. And then there's a short follow-up period. It was about 6 months. So it allows for initial assessment, but longer follow-up usually, I think, needed to assess long-term durability of the effect. And then appraisal for population examined. Strengths, I think, well-defined and focused on a specific population with AERD. Patients helps generalizability of the study within this group. There's no significant differences in the baseline characteristics between the study groups, which is good because we want them to kind of be similar to each other. And it was, again, randomized and stratified to the severity of CRS, which kind of limits confounding factors. And I think appropriate inclusion and exclusion criteria. However, weaknesses, the study could benefit from exclusion of patients with underlying airway obstruction, like those with obesity, asthma with polyps, higher Mallampati scores, because this could also be a confounding factor. So I was kind of thinking about that and thinking that it'd be interesting to see if those people were included in this study and how that could have skewed data. And then appraisal for results, I think strengths are, it was unique and it was a novel comparative study, definitely. I didn't see much or any really studies similar to this one. And results are definitely clinically relevant to the patients that we see. And it shows the statistical significance in biologics targeting IL-4 and IgE groups for NSAID tolerance. As far as weaknesses for results, I have limited outcome measures focused on NSAID tolerance and symptom-based comparisons, but could also compare pre-treatment and post-treatment total IgE and serum eosinophils in relation to NSAID tolerance for stronger results. Appraisal for future studies. So mechanisms underlying differential effects of anti-IgE, anti-IL-4, IL-13, and anti-IL-5 therapies in NSAID tolerance. Sorry. Larger sample size would be good to see in the future with a study like this to kind of see how that changes and, do we see kind of the same things or do we not? Cost effectiveness, I think, would be interesting to see for this. Broader NSAID tolerance beyond the aspirin, and then differential effects in subgroups to help personalize treatment strategies. And then quality of life assessments for these patients. So my overall impression, this shows promising preliminary evidence that biologic therapies may be effective in including NSAID tolerance. However, limitations of the study necessitate further research with larger sample sizes, longer follow-up periods, and broader outcomes measure. And these are my resources. And any comments, suggestions, or thoughts on the article, would love to hear.